update the School Sports Head Injury Prevention Act, and it is 22 RS 2647.
You guys get that? All right. Thank you, Tom.
Thank you, Madam Chair.
Are there any other bill introductions? All right. Seeing none, we're going to go ahead and open up the hearing on House Bill 2463, and I'll recognize our reviser, Scott Abbott.
Thank you, Madam Chair, and good afternoon, committee. House Bill 2463 was pre-filed. It is an act relating to the medical assistance or Medicaid program. The bill would prohibit any state agency from making any substantive or material change to the Medicaid program prior to January 1 of 2026. Would also require the extension of the current Medicaid program as it exists when the bill is enacted through December 31 of 2025, or a 2-year extension of the current program. It also directs the Secretary of Health and Environment to negotiate for the extension of the contract for the managed care organizations for that additional 2-year period to continue administering the Medicaid program. And as with all other Medicaid bills, it directs KDHE to submit any approval requests necessary to the federal government. Madam Chair, the bill will take effect upon publication in the Kansas Register, and I'd be happy to take any questions.
Okay, and I know that there's been a lot of questions on the dates that we have in here. And you and I had discussion the other day also with Arida that it has to do with the fact of, because the contracts, I believe, expire 2023. Do we know what month that is, Arida? I should know that, and I don't.
Madam Chair, that's December 31st, 2023.
Okay. So we have that, we've got to get through those years. Then we have a year to allow the next administration, whomever it is, to do an RFP. Then it takes maybe a year more or less, we never know, with CMS to get their approval, and then to get all of our contracts in order. And that's why this date looks like it's as long as it is. So kind of a brief explanation of it. And I will have to apologize. I know that Representative Armbarger has been catching a lot of flack, and perhaps I was not clear on my instructions that it would be a committee bill, but she's bucking up and taking it. So this is a committee bill. It's not Representative Armbarger. So if you got questions, make sure you come to us. Are there any further questions for Reviser Abbott? Representative Wolfmore.
Thank you, Madam Chair. We just were given an amendment here, a possible amendment. Can I ask him a question about that?
Yeah, what I'd like to do is I asked him to go ahead and hand it out today, because Scott and I visited the other day, and have him explain it right now, and then we will take questions on it. So that's my next step, if you give me just a moment. Are there any further questions on the bill as it exists right now? All right, now if you'll explain the amendment that you and I worked up.
Sure, Madam Chair. And I just handed out a copy to all the members. You should have that. There are a few extra copies here. And it should be posted to the committee's website under the materials for today's meeting here shortly. But the amendment is largely clarifying in nature. It provides that this bill would not prevent KDHE or any state agency from doing something that is required by another act or a budget proviso that is passed into law by the legislature, or something required by federal law or by CMS. I think that's true, probably, even if you don't say it, but this would make it completely clear.
Okay, the one thing that I'm not sure, and I'm sorry, Representative. So do you feel then that this language still gives the legislature? Okay, so that's the Appropriation Act. Okay, never mind, I didn't read that, so I apologize. Representative Wolfmore. I answered my own question. That's scary now.
And he answered mine, but thank you.
Okay. Are there any further questions of Reviser Abbott? Okay. All right. Seeing none, thank you very much. Dave did let me know it is uploaded on the website. So for those of you that want to see it, that may or may not have gotten a copy of it. Okay. We have, shock and awe, no proponents of the bill. So we're going to start with opponents, and I have up first Sarah Fertig, our Medicaid Director with KDHE. Welcome to committee, Sarah. It's good to see face-to-face people. I'm loving it. Nope.
There we go.
Okay.
There we go. Thank you, Madam Chair. Good afternoon, committee. It is lovely to see you all in person. My name is Sarah Fertig. I am the State Medicaid Director. I work for KDHE, and we do appreciate the opportunity to appear as an opponent regarding House Bill 2463. And generally speaking, our opposition to this bill, it's for a number of reasons, but those reasons can be generally categorized into 3 buckets. First, our concern is that the bill as written would require us to stop routine maintenance and updates of the Medicaid program. Secondly, we're concerned that the bill as written would stop us from having any changes to the bill that constituents in the legislative branch have been asking us to do. And then third, we're also concerned about how the Centers for Medicare and Medicaid Services, or CMS, would respond should this bill pass and should KDHE be directed to take the actions that the bill is directing us to do. We also submitted written testimony for the committee's benefit, and I'm going to kind of go along with our written testimony to kind of organize our thoughts. So at the top, Madam Chair, we're concerned that this bill is pretty vague about what types of changes it would prohibit us from making. Subsection A of the bill says that it would bar any substantive or material change, but does not tell us what that means. We go through a lot of federal and state dollars for the Medicaid program, and so even something that we find pretty minor could have a fairly large fiscal impact, $50,000 or so. So it's not really clear to us what we would be barred from doing, and as a result, our concern is that it would block us from really doing any changes to the Medicaid program, including the type of ongoing and routine maintenance that we do for our program. So for instance, anytime there's a new drug that comes online, we are required by federal law to add that drug to our formulary if the manufacturer has a drug rebate agreement on file with the federal government. We are also frequently asked to start covering new and emerging treatments, services, new therapies, that type of thing. For instance, as of January 1st, we're covering a treatment called Cologuard. It is a non-invasive colon cancer screening treatment that's not only cheaper for the state, but it's also non-invasive and better tolerated by folks with medical or disabilities that would make the prep for ordinary colonoscopy pretty trying. So all the time we're presented with requests from the medical community asking us to cover these types of newer, cheaper therapies. And our concern is that this bill would stop us from doing that for 4 years. We are also concerned that it would stop us from doing any pending increased provider reimbursement rates. For instance, we're in the process of seeking CMS approval to increase the global pregnancy rate. Providers who help Medicaid moms with their prenatal and postnatal care and deliver babies, they have not seen a rate increase in well over a decade. And we think it's high time that we increase that. So we're working on a modest increase that requires CMS approval. If this bill were to become law before then, that would be stopped in its tracks. We're also required to update our MCO capitation rates periodically to make sure that they remain actuarially sound. This potentially could draw a stop to that. And many of you participated in various interim committees that considered recommendations to improve the Medicaid program. A concern of ours is that we would not be able to implement those recommendations. And another ongoing project that we're working on is seeking CMS approval to finally implement the bill that you all passed in 2020 that would expand the hospital provider assessment program. We've been working on getting CMS approval for this change since 2019. We've seen some optimistic signs from them that they might be willing to let us implement that program. If this bill became law, in all likelihood, that would be stopped. So generally, these are some of the concerns that we have about ongoing projects that we fear this bill would stop in its tracks, although we do reiterate that it's not entirely clear what all we would be prohibited from doing. But we're also concerned that it would stop some of the projects that our constituents have been asking us for and that we've heard a lot about, particularly in the interim session. So during the 2021 interim session alone, the KDAD's Autism Task Team met, and there were also at least 3 special legislative committees and 2 standing joint legislative committees that considered recommendations on how to improve the Medicaid program. And so we heard from proponents of various changes, such as extending coverage for pregnant women for Medicaid to 12 months postpartum, adding certain behavioral health codes to Medicaid coverage, finally addressing some of the wait lists for home and community-based services waivers, in particular the IDD waiver, improving access to therapeutic services for kiddos with autism, and very critically, addressing some of the workforce shortages that are making it difficult for folks with disabilities to access the home-based services that they need to continue to live safely and happily in the community versus being put into an institutional placement. So our best guess is that each of these projects would be considered a substantive or material change to the program, and we would be blocked from implementing any of those for about 4 years. So we would have to kind of stop all discussions with legislators and stakeholders as to those projects. And lastly, we do have some concerns about how CMS would react to this bill if it were to pass. Our current Section 1115 waiver that we operate the CanCare program under includes special terms and conditions that condition our receipt of federal funding to the state complying with certain rules. One of those rules is that we have to quickly and promptly and timely comply with any federal law that affects the way Medicaid does business. And we also have to quickly implement any CMS directives that come down, and they come down very frequently. So if we fail to do that, all of our federal funding for Medicaid is at risk. And for a little bit of context, in fiscal year 2021, we received $2.9 billion from the federal government to operate Medicaid. And this is not just capitation payments that go to MCOs. It goes to pay for staff salaries. It goes to pay for the IT systems and the like. All of that could potentially be at risk if we are forced out of compliance with the CMS rules. And also for frame of reference, during fiscal year 2021 alone, we paid our 3 current managed care contractors about $3.9 billion, combination federal and state. We've got the exact figures in our written testimony if you're curious. But we're also concerned that CMS might not even allow the state to implement House Bill 2463. And as a reminder, Medicaid is a state and federal partnership, and CMS sets the rules that the state must comply with as a condition of receiving federal funding to pay for Medicaid. They have to approve all of our contract amendments with the managed care organizations, and they also have to approve the federal authority under which we operate the CanCare program. Currently, that's a Section 1115 waiver, a demonstration waiver that expires at the end of 2023. So the way this bill reads, we would be required to keep our current Medicaid program in its current form through the end of calendar year 2025. And while the bill isn't clear, we kind of assume that means that we would be required to ask CMS for a 2-year extension of our Section 1115 waiver. As part of our due diligence on this bill, we reached out to CMS on Monday, and they told us that under no circumstances would they allow that. They would not allow us to amend or extend our 1115 waiver for 2 years, 1 year at the most. And so if this bill were to pass in its current form, we would potentially be in an awkward position where we would be required to extend our federal authority for 2 years, but we wouldn't be able to do it under existing federal authority. And the way the bill is written, it could prohibit us from shifting to a different source of federal authority, like the ones we've been talking about with some of the committees we appear in front of before long. So it could put us in kind of an awkward position where we could neither comply with state law or federal law in that regard. And ultimately, really, the only choice the state would have is to renew our current Section 1115 waiver that's currently standing in the way of us implementing a lot of the changes to the Medicaid program that the legislature has asked us to do. So it's for these reasons, Madam Chair, that we stand in opposition to this bill. But one last one that I want to highlight is that this bill as written would bar us from going through the normal and routine competitive bidding process for managed care organizations. As I indicated before, these are very high value, high dollar contracts, and it's really important for that amount of money that the state is reassured that we are getting the best value for that dollar. And during the last round of competitive bidding, the 3 MCOs that we awarded contracts to provided the best value for the dollar. This bill would require us to give 2-year no bid extensions for the 3 current MCOs. And for that 2 additional year period, we would be deprived of any market innovations and any additional services that could potentially benefit the state that would come from the results of a competitive bidding process. And we're also concerned that that bill as written would require us to extend the contracts for the MCOs no matter what, which means that no matter what happens, we would not have the ability to threaten termination of those contracts. Now, to be clear, we have an excellent working relationship with all 3 of our MCOs. I cannot see it coming to this point, but it's still, for compliance purposes, very helpful to know that we would have that nuclear option in case something went very, very sideways. This bill would take that option away from us. So, Madam Chair, it's for these reasons that KDHE stands in opposition to this bill, and I'd be happy to answer any questions at the appropriate time.
All right, and I think, Sarah, what we'll do is we'll get through all of our opponents, and then we'll circle back for questions of everyone. Next, I have Heather Braun, Health Policy Advisor, Kansas Action for Children. Welcome to committee.
Good afternoon, and apologies, I'm nervous. This is my first testimony before you all, so.
We don't bite.
Thank you.
Well, not much. Okay. Yeah. Just so you know, my ranking said that.
Thank you, Representative Reese. Chairwoman Landwehr and members of the committee, thank you for the opportunity to share our concerns with House Bill 2463. My name is Heather Braun, and I am the Health Policy Advisor with Kansas Action for Children, a nonprofit advocacy organization working to make Kansas a place where every child has the opportunity to grow up healthy and thrive. We weigh in on CanCare-related issues as 75% of CanCare enrollees are children and their parent caregivers. According to KDHE CanCare enrollment data from September 2021, 62.3% of CanCare's enrollees are children. Another 13.1% are parents or caretakers of children. We oppose House Bill 2463 for 2 reasons. First, we believe that the current MCO reprocurement process must move ahead as scheduled and planned. If this process is pushed back several more years, the state of Kansas delays addressing the much-needed improvements and accountability for services provided by the MCOs, including data collection and data transparency issues, provider network adequacy, and those services that address social determinants of health for children and pregnant women. Second, we are particularly concerned at how broad the language in Section 1 of the bill appears to be. As you've already heard, there is no definition for what substantive or material change means. We worry that this language would force the CanCare program to lose timely and responsive flexibility and prevent possible program changes from being implemented, as you already heard from Director Fertig. In conclusion, CanCare is a critical program for children in our state to access preventative healthcare services. As data, research, and experience evolve, we ask that you prioritize improvements to the program instead of hindering those processes. Allow the MCO reprocurement process to move forward on its current timeline. Please do not pass this bill. Thank you for the opportunity to testify today, and I'll stand for questions at the appropriate time.
All right, thank you very much. Next, we have Sean Gatewood, CanCare Advocates Network. You're back again.
Yes, Madam Chair, I can't get enough.
You're welcome to the committee.
Thank you. Thank you, Madam Chair, members of the committee. It's a pleasure to be in front of you today. The CanCare Advocates Network, we are here in opposition to this bill for all of the reasons that Director Fertig already lined out. But I want to kind of go back over just the basics of for the benefit of members that were not here back in 2012, and then when we redid this back in 2016. An 1115 waiver is a demonstration waiver. And so it is the state has to put together a hypothesis and say, well, we think that this will be a better way of providing care in our state and a more efficient way of providing care in our state. Ours here in Kansas, CanCare says that, having private insurance companies will drive care by competition. Them competing against one another will bring, sorry, this mic's a little low for me. It will bring more services, better services for all the, folks that are served by CanCare. What this bill does is it extends out that timeline and frankly kind of defeats the purpose of an 1115 waiver. It needs to be a constant cycle of, the hypothesis, learn, apply, repeat on a fairly short timeline, and that's why CMS has fairly short timelines for renewal. So again, not only are you not reapplying and having folks sort of competing again, especially given the climate that we have in healthcare today, which is very fast, evolving. We think that we could get better care and the bids would be much more timely as opposed to what we have right now going into the future. So we have those concerns. We also have the same concerns about CMS and where we derive the authority, given that the extensions are exhausted. So thank you very much. I will be here to answer questions at the appropriate time.
Thank you, Sean. I appreciate that. And committee, you will note under opponents, we have written only from David Jordan, President and CEO of United Methodist Health Ministry Fund, Kansas Department of Aging and Disabilities, aka KDADS, Denise Seisman, Community Care Network of Kansas, Tanya Dorf-Bruner, Oral Health Kansas, D'Angela Burns Wallace, Secretary, Kansas Department of Administration. Is there anyone that we missed that was supposed to be on the list and we didn't call your name? All right. Then neutral, we have Rochelle Colombo with the Kansas Medical Society. Welcome to committee.
Thank you. Good afternoon, Chairman Landwehr, members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society, and I appreciate the opportunity to provide brief comments before you today. I will keep it very simple. I think Director Fertig covered some of the concerns that we had. We are neutral conferees. We don't have concerns with CanCare program, nor do we have a way to really engage in the conversation around contracting. There is some confusion about how broadly this could be applied. But for some historical purposes, the Kansas Medical Society was very involved and supportive of working with the administration and with providers to move the state to a managed care program. We have worked on the implementation of that and making sure that it's successful in achieving the goals that were outlined. Our concern with the 2463, I don't know if it would be addressed by the amendment. I will happily look at that and try to provide response after I do. But our concern is that physician fees for Medicaid have been frozen since 2006, so for a full 16 years. And obviously, it's important that we continue to have physicians continue to participate in the state's Medicaid program. They are not compelled to do so. They do so willingly, and the majority of Kansas physicians do participate in providing Medicaid services. But Medicaid reimburses at a rate of about half of a private payer. And as we have increased utilization and those fees have stayed stagnant, we're going to likely see physicians take a smaller percentage of their practice and dedicate that to Medicaid services, which will, constrict services and is counterproductive to the goal of making sure that we've got that access. So our concern would be if this further limits the ability of the state to increase physician fees over the course of this freeze. We would not support that, but I would be happy to look at the amendment and see if it addresses it, and appreciate the opportunity to appear before you today. Happy to stand for questions.
All right, thank you. Next, we have Tara Mays with the Kansas Hospital Association. I flipped over my agenda and couldn't find it.
Thank you so much, Madam Chair, members of the committee. I am Tara Mays with the Kansas Hospital Association. Very much appreciate the opportunity to appear before you today. I will also be very brief in my comments. We appear before you today as neutral conferees on House Bill 2463. We did, as we looked at the bill, want to raise a few concerns for you as committee members as you're considering the legislation before you that we've heard from our members. Many of those I think Director Fertig touched on, but I will just very briefly highlight those. One of the most concerning elements really deals with the Healthcare Access Improvement Program in the state of Kansas, or what's commonly referred to as the Hospital Provider Assessment Fee. Currently, as Director Fertig mentioned, that is before CMS for approval, so we would request that any amendment be considered to allow for changes to HCAP should CMS grant that approval so that there's no negative consequences there. In addition to that, as our hospitals have taken a look at the legislation, a couple of other things that have just been raised with us is obviously locking in the current rates for Medicaid providers, as was mentioned by Rochelle Colombo. In addition to that, making sure that we don't prevent the use of new drugs and treatments for patients in the state of Kansas, as well as impact to the state's ability to address telehealth-related changes to the program to assist us in addressing any patient's access to health care in the state of Kansas would be a few things that our hospitals would just want to make sure that this committee is aware of. And I haven't had the opportunity to review the amendment either, but those would be a few things that we would just raise with you, and I'd be happy to stand for questions at the appropriate time, Madam Chair.
All right, thank you very much, Tara. Committee, we also have written-only testimony from Kyle Kessler, Executive Director, Association of Community Mental Health Centers of Kansas. Was there anyone else that had thought they were on the list and they are not? All right, seeing none, now we'll be happy to take questions. What I'd like to do, committee, once a conferee gets called up and you have a question for that conferee, we'll kind of go out of order of whenever you maybe raised your hand, just so we don't have them bouncing up and down like little jack-in-boxes. So I do have one question for Sarah. Sarah, on your testimony, when you talk about the $2.9 billion and the $3.9 billion, is the federal side, is that with the enhanced FMAP or that we're getting with right now, the extra 5%?
That would be, Madam Chair, for state fiscal year 2021. We are currently receiving 6.2% additional federal matching funds as part of federal coronavirus relief legislation.
So my next question to you to follow up on that is, how much of that $2.9 billion is actually going to Medicaid? Because I think some of the enhanced is going to other services. Would that be correct?
That's a good question. Now, the figure we have here, this all goes to pay for Medicaid. We are drawing down a significant amount of money with that additional 6.2% FMAP. The last figure I saw was that through the end of the summer, that it amounted to about $450 million. So that's offsetting state general funds that we would normally be spending to pay for Medicaid. But all of that entire $2.9 billion, that is all federal dollars, all going to support Medicaid.
Okay, so some of the increased FMAP is coming into this.
That's correct, Madam
All
Chair.
right, thank you. Are there other questions for Sarah Fertig? Representative Wolfmore.
Yep. Thank you, Madam Chair. So I am struggling a little bit with this bill because normally we have proponents on a bill, and so I have no one to ask what the real purpose of the bill is, but I do have some concerns with them based on the testimony. So we heard that the new drugs that come online, as in any insurance company, would be expected to be covered, that might not be able to be covered. I think you said the 1115 waiver needs to be changed, but under this bill, it couldn't be changed, and so we'd be in a tough spot there. We'd have a problem with the hospital provider assessment fee. I think the one that might concern me the most, and I haven't read the testimony from the Department of Administration, is procurement issues. So this would set up a no-bid process because these contracts would automatically stay in force. And then I think you said, which I think would be especially concerning, is that you'd really have no hammer if there was any kind of unfulfillment of the contract, bad actors. I mean, I'd love to be a contractor of the state if I knew I could do anything and they couldn't enforce or use any hammer on me. So I see all those problems, and I assumed the amendment would fix a litany of other things, but I wondered on things like, for example, we passed, the chairman's aware of it because she worked so hard on it, the CCBHC, and we had to phase that in because of budget neutrality issues over the next few years. Could this affect something like that? Because would that be considered changes to the Medicaid program?
Well, Madam Chair, I would be really hard-pressed to argue that fully phasing in the Certified Community Behavioral Health Clinic program would not be considered a substantive or material change to the Medicaid program. We are set to bring the first 6, I believe, CCBHCs online in May. This bill would take effect upon publication in the register, so I don't think any of them would squeak in before that deadline. And then the remaining CCBHCs would be phased in over the next 2 fiscal years.
Okay, thank you. I will reserve any other questions for the future. Thank you, Madam Chair.
Representative Barker.
Thank you, Madam Chair. Sarah, you weren't aware of this amendment when you drafted your testimony, I would imagine.
That's correct.
Have you looked at the amendment?
Yes, Madam Chair, I have had a chance to review the amendment.
Okay. How would that affect your testimony if the amendment was attached to the bill? Because it says specifically to present, any action required by this act or appropriations act, so it could be changed. And it also any changes in federal law, United States Center for Medicaid, Medicare and Medicaid services. So in that amendment, it kind of covers that if they make a change, you would be able to make a change.
Madam Chair, that's an excellent question. So thank you, Representative Barker, for asking it. So yeah, we had not seen that amendment before we appeared today. So that would cover instances where we are required by federal law to do something. So for instance, when we are required to add a new drug to the formulary under federal law, that would cover it. Some of the other pieces that we have, like making sure our MCO rates are actuarially sound, it would cover that as well. And when the CMS would hand down a mandate, you have to cover XYZ service, it would cover that as well. It wouldn't take care of all of our concerns, however. And we do remain concerned that CMS might not even approve the operational documents that would be necessary to implement this bill, such as the MCO contract extension and the extension of our Section 1115 waiver.
Thank you very much.
Further questions of Sarah Fertig? Representative Reese. I'm sorry, you did say that.
That's okay. Because in our Social Services Budget Committee, we, are looking at funding for the intellectual disability waiver, the IDD waiver. And one conversation we've had is asking for a second waiver to accompany that would just be for social supports and to help relieve the 4,000 plus people that are on that wait list. It wouldn't replace it, but would just give some relief to it. Would we not be able to do that if this bill passes?
Madam Chair, to answer Representative Ruiz's question, again, I don't think that we could argue convincingly that creating a new HCBS waiver, like what was discussed in the IDD Waiver Committee, would not be considered a substantive or material change to the Medicaid program. So I think we would be barred. I think KDADS maybe spoke to this in their written testimony. We suspect that we would be barred from creating a new waiver to address those types of needs or amending the ones that we currently have.
Thank you. Thank you, Madam Chair.
Are there further questions for Sarah Fertig? All right, seeing none, thank you, Sarah, I appreciate it. Committee, are there questions for other conferees? Representative Wolfmore.
Thank you, Madam Chair. I have a question, but I don't know who to direct it to.
Well, let's ask it, and we'll figure out who that belongs
I'm
to.
trying to, we've heard the problems, even with the amendment. I mean, I think there still could be significant problems, especially when it comes to the extension of the 1115 waiver, not to mention the procurement issues. I'm trying to figure out what problem this bill is trying to solve or what we're trying to accomplish with it. That might be helpful.
And as I stated, before we started the hearing on this, is the idea is to give whomever the next administration is the opportunity to go into the long-term contracts with CanCare. So by extending it, then the next administration comes in and deals with it. That's the intent. Are there further questions for anyone, any of our other conferees? Okay, does anyone want to discuss the amendment?
Can we share opinions about it?
Oh, absolutely. I mean, remember, we'll have a hearing, or we'll work it at some point, but I think that because there's been a lot of, because we've had a lot of concerns raised on this, anything that anyone wants to talk about or that their concerns are, I'd like to get that started today so that we can have answers. If we can't get them today, that we have answers at the time we do work the bill. So feel free to go ahead and do it. You may or may not get an answer, but we will have them by next week.
Thank you, Madam Chair. Again, I have a lot of concerns, but I guess the one that Representative Wolfmore mentioned was, not knowing, I'm used to bills coming to us because we want to fix something, we want to enhance something. And this is just out of that realm, and it's so that we can allow the next administration to negotiate the contracts. And it just feels like to me that there's just so many problems with just waiting. So I think I'll reserve the rest of my opinion when we actually work the bill, but that's part of what my concerns are.
All right, that's fine. I just want us to be out front with our discussions. I really appreciated the discussion I had last week with Sarah Fertig, because she laid out some concerns, I laid out some concerns, and we were all on the same page. And other people that have expressed some concerns were pretty much along the list of what Sarah had presented. Obviously, we don't want to impact our CCBHC legislation, so we got to figure out how we address that. I know that Representative Carpenter's committee is working on the IDD piece. I don't know all the details, but I'm supportive of it. We also have the issue of postpartum, that both the CanCare Oversight and the Mental Health Modernization Committee supported very strongly, again, bipartisan support. The provider reimbursement rate that we heard earlier, I believe that was with our hospitals, was that correct? I believe. Let's see, what else was it? The issue with the 1115 waiver. We're hoping that with the amendment that we address the issue of who could. So if I'm understanding it correctly, and Revisor Abbott will correct me, the intent would be is that the legislature can make changes. The agency can't make changes. So if the agency sees a problem that needs to be addressed, they can have the legislature come in there and address it. I might note that it's not the first time we've extended the CanCare oversight contracts for things, so this is not necessarily an unusual. Are there further questions or comments? Representative Hesswood.
Thank you, Madam Chair. One of the biggest concerns looking at the fiscal note that said that KDHE and KDADS were unable to make a fiscal impact with the non-definition of substantial or material change. After listening to testimony, do we have more of an idea of definition of that?
Well, and Scott, correct me if I'm wrong, I feel that our amendment addresses that by allowing the legislature to give authority for that change to occur. And I would be surprised if, knowing we don't know what our body will be next year, we've got elections up, but for the most part, we'll be pretty supportive of the things that we're concerned about, the rates, the CCBHC, et cetera, the postpartum, because we're all in agreement with that. Representative Lynn.
Thank you, Madam Chair. You mentioned that there have been other times where we have not, where we've extended the contracts beyond those 3 years. Would we be able to get a time frame or the instances where that occurred and for the reasons that they occurred?
It was one, and it was done by executive order.
Thank you.
Representative Kelly.
Thank you, Madam Chair. As I've sat here and listened on this, my mind wanders around some on, could the possibility of the extension where you'd rebid 2 years earlier, it would cost you more money to extend it than you might be able to save with the new contract bid and the new services that you could put in, that it would spend money that you wouldn't spend in those last 2 years and kind of put yourself in a hole to work out of?
Well, and I'll be happy if Sarah wants to jump in here on this, because it would be my understanding, again, that the legislature can make those changes. And I think, Sarah pointed out in her testimony, she talked about the, how did you say that? The fiduciary, basically solvency with our Medicaid, our MCOs that we have out there. So again, the agency can come to the legislature and we can authorize that. The agency cannot authorize it and we're trying to clear that up. And maybe there's more language or better language that we need to put into this amendment. It's just that that's what Scott Abbott and I came up with preparing for this meeting, because I wanted to make sure that everything was out front, that we're having discussion on it. My hope and goal would be that we come out with, like most of the things that we do in this committee, which I've been very blessed with, is that it's done bipartisan and not by a lot of division. So if people have recommendations and they have suggestions for language change, we are open to that. This was just my start. Does that answer your question? I don't think that there's a savings to be had. I think the issue is making sure that our MCOs, if the rates need to be changed, that the agency and the MCOs would be able to do that, but the legislature would have to approve it. Would that be correct, Sarah?
Madam Chair, we're kind of into uncharted territories in terms of what we would be doing with our MCO contractors. What I would imagine we would be required to do is try and negotiate a 2-year extension with our current MCOs. And to Representative Kelly's question, we would be a little bit, our bargaining position would not be optimal, because we would be directed by the legislature to extend the contract. And so we would have to do that, which would give the MCOs more leverage to request changes to the contract that the state might not necessarily support. In terms of the amount of money that we pay to MCOs, however, that's all governed by CMS actuarial rules. So I don't think that's necessarily a threat, although rates do tend to go up each year because health costs go up each year. So that's not super surprising, but other aspects of trying to extend for 2 years could be problematic.
Committee, further questions? Representative Clifford. I'm sorry, I had to pause and remember who I was talking to. Welcome to committee, by the way.
Thank you, Madam Chair. It's a pleasure to be here. I share with Representative Ruiz concerns about some of the unintended consequences. I'm particularly concerned about the HCAP increase. We squander potentially 2 years of effort to get that with CMS. Ms. Colombo alluded to the fact that physicians and non-physician providers will migrate away from the low Medicaid rates. We looked at it yesterday in the Social Services Budget Committee, and for eye care, those rates, even with the enhancement, are 60% of Medicare. And I'll tell you how that works in practice. We have open doors in our practice. I'm sure Dr. Epley does too, but providers of care will take Medicaid patients, but they'll have 2 appointments a month. And that's how they limit the care, because they'd rather take the Medicare patients where the reimbursement is much greater. So I do think this jeopardizes all the work towards enhancing those rates. Thank you, Madam Chair.
Well, and isn't it accurate to say that not all Medicare policies have eye care, or am I incorrect on that?
Madam Chair, as a medical necessity, all Medicare recipients are covered.
Okay, thank you. Further questions or comments?
Can I have another question?
Yes, Representative Reese.
Thank you, Madam Chair, for the second question.
You can have how many ever you want.
Okay.
Representative Armberger can't.
She can't.
She reached her limit.
Poor thing.
Not today, she did last week.
So it rolls over.
It might. I do it on a case-by-case basis, how I feel that day.
Got it. So you mentioned, Madam Chair, that the legislature would give authority to agencies that needed to make some changes. What kind of a timeline would we look at? Once the let's say, KDAD's asked for a change, how long would it take for the legislature to make those changes?
Well, seeing as how we can't control the legislature, I can't even control this committee most of the time. I can't tell you that, but it would, it would be through a legislative, probably time period, through a session. And, that's kind of where some of these changes occur anyway. Representative Clifford talking about rate changes, and I don't know where Representative Carpenter might be taking that. We've known for a long time that our Medicaid rates are way too low. And that would actually be one of the reasons that I oppose Medicaid expansion. Until we take care of our existing obligations, it's kind of tough to bring on a new program and then try to get more providers when they're hesitant to take Medicaid clients anyway because of our rates. So I understand what he's saying, but I don't know where Representative Carpenter's taking that. I'm not on that particular committee, but I am on a PROP, so we will hear it as well as Representative Wolfmore. Sarah.
Thank you, Madam Chair. I know it's irregular for the conferee to ask to speak, but just a little bit of information that might help kind of inform this discussion about having the legislature decide when Medicaid can make changes. And to follow up on the comment that Representative Reeves made, sometimes we have to take action very quickly when the legislature is out of session. And I can give you a recent example of this. In either July or August, we became aware that a provider of certain disability services was going to pull out of the Medicaid program because our rates were too low, effective almost immediately. And this particular provider represented 50% of the state capacity for this particular service. So we had to take pretty swift action. What they were asking for was minimal. I think the fiscal impact was under $60,000 for an entire fiscal year. But we had to act immediately, otherwise that provider was out the door, and there went 50% of our capacity for that service for disabled working Kansans. So it's not uncommon for us to have to take swift action to maintain the provider network and to avoid providers leaving the Medicaid program outside the normal legislative calendar. And that happened as recently as last summer.
Okay, and Sarah, when you're talking about provider rates on that, are you talking about with our MCOs or with individual providers?
Madam Chair, that was with an individual provider. Under our MCO contracts, the MCOs are not allowed to pay below the Medicaid floor, but our contracts incentivize them to stay roughly at the Medicaid floor and not go above it unless it's necessitated due to individual circumstances. So we had to raise the Medicaid floor rate in order to keep this provider in our network.
All right, thank you. Representative Arnberger.
Thank you, Madam Chair, for letting me have an ability to talk today. I have a quick question for Sarah and for you, if I can direct it to both of you.
Sure.
I know that the 2025 date was the ideal. Sarah, in your testimony on the second page, you mentioned that KMS will not, CMS, not KMS, will it says on here, not a 2-year extension, but would they do a 1-year extension? Did I hear you say that portion? So the question I have for the both of you is 2024, would that eliminate that concern? Is that a possibility?
Madam Chair, yes. So CMS did grant the state a 1-year Section 1115 waiver extension in 2018. So the original CanCare 1.0 Section 1115 waiver was for 6 years, not 5. So they did grant us that 1-year extension. They've told us that they will not go beyond 1 year. If you're asking for more than 1 year, you either have to renew for another 5-year Section 1115 waiver period, or you have to shift to a different source of federal authority.
Okay. Thank
And
you.
when you say a different source of federal authority, you want to elaborate on that a little bit?
Sure, Madam Chair, I'd be happy to. So this is something we've been discussing with the Bob Bethel Committee, and it's come up before, I believe, in social services budget. But one of the things that we're looking at as the state Medicaid agency is whether the structure of the Section 1115 demonstration waiver has outlived its utility for Kansas. So when CanCare first came online in 2013, Kansas was, if not the first state, one of the first states to roll virtually every Medicaid beneficiary into mandatory managed care. It was really very innovative at the time. And so the state decided a Section 1115 demonstration waiver was the appropriate way to go because it was so innovative and it truly was a demonstration project to pilot a new way of delivering Medicaid to the state. We've since renewed that 1115 waiver, and now we're wondering whether it's time to shift to something else. You know, CanCare has been around since 2013. Here we are 9 years later. This is not a pilot project anymore. And with an 1115 waiver, you get a lot of flexibility from the feds, but you also are subject to very, very strict caps on how many federal dollars you are allowed to spend. And that is why, Representative Clifford, we have been unable to implement the HCAP expansion because it would exceed the caps the feds have set for us in terms of how much we can spend through the end of 2023. So it's for that reason we've been looking to see if another source of authority could make more sense. If we were to shift to a different source of authority, Medicaid beneficiaries, providers, and even the MCOs would not know the difference. What it would do is change the relationship of the state to the federal government and change the types of reports we would have to file, and it would take away the strict spending caps on how much federal money we can spend. So it's something we've been evaluating. No decisions have been made. But this bill would block us from doing that.
Thank you, Sarah. Representative, are you good with that? Representative Epley.
Thank you very much, Madam Chair. And I guess, I'm not sure who this is directed at, but I'm going to just make a comment, and if you want to jump in here, that'd be great. I appreciate the intent of House Bill 2463 and even the amendment to try to make it a better bill. I think it probably is better than where it was. As a physician that's dealt with the HCAP and the lack thereof, I think it's already had some detrimental effect in the state. I can't give you any metrics, but I'm pretty certain of that. I understand this is well-intentioned to provide more legislative engagement and oversight with this program as it evolves from, you know, Medicaid 1.0 to Medicaid 2.0 and the managed care days. And I don't know, any of us know where we're going exactly, but without proponent testimony, it's a little hard for me to really embrace what the goal of this bill is. And so I know you outlined some of those goals, and I kind of get it, but are there any other proponents other than just trying to keep us oversighting this and keeping a good eye on the costs that are involved with this program? That's my question.
Well, as I said earlier, the intent of the bill is to give the next administration, whomever that is, the ability to enter into the new long-term contracts versus what we have now. So that's the intent of the bill. Sarah, now I forgot what I was going to ask. See, you messed me up, Epley. Oh, dang it. I'll get it back here in a minute. Someone else have a question? Do you have another one?
Oh, come on, Tori.
Come on.
Representative.
Huh? We don't need any jokes. Did you have one? Representative Meyer, I'm sorry.
Thank you, Madam Chair. First question. So I appreciate you hanging in there with me. I am new to the committee, so maybe I don't understand this, but is there anything currently that is standing in the way of the next administration being able to perform their duties to extend those contracts? Because I'm kind of not following it. It sounds to me like this bill is being proposed so that we can provide the opportunity for the next administration to do that. But I'm not aware of anything that currently stops them and prevents them from doing that. So I was hoping that you might be able to explain, since I'm so new to the committee.
Well, they wouldn't have the ability to renegotiate those contracts.
And why is that? I'm just looking for some background.
Sarah.
I'm sorry.
Thank you, Madam Chair. And Representative Meyer, the way our current timeline is for the next CanCare RFP, we would not be able to release it until the fall. The last time a CanCare RFP was issued, there was a 90-day period that interested companies could bid on it. And then it takes several months to review the bids and decide on a successful vendor. So in all likelihood, we would not be able to award the contracts until spring of 2022, late winter, 2023, late spring or early winter. So March-ish under our current timeline.
So that's kind of the idea behind this, is to give the next administration kind of a clean slate to come in and put whomever's stamp on it.
Thank you, Madam Chair.
Representative Blacks.
Thank you, Madam Chair. And I agree, it's a little bit difficult when we don't have proponents. The benefits of a committee work is to hear all sides and then make a somewhat intelligent decision. I guess you've outlined some of the problems, but if we, and I think our goal is to have legislative oversight, and certainly I think that's important for any state agency. I sometimes realize state agencies don't want to give that up and don't want to have that, but at the same token, it's our public responsibility. So if in fact we do have some of these problems come up, how difficult is it to get extensions to operate under the current situation? Is that a huge obstacle for you? You covered a little bit of them small issues, and I kind of understand that. And I believe that, we have a state agency that's there for that, and we need to, what kind of an impact you'd have to be able to operate under the same extension. How difficult?
That's a good question. And Madam Chair, it's administratively time-consuming. It's not just a matter of calling CMS and saying, hey, can you please extend our 1115 waiver? There's a whole application process, and they have to review it. And so there is an administrative burden in terms of the amount of staff time that we would need. CMS, if we had a good operational reason for asking for a one-year extension to our 1115 waiver, I think they would grant it. They have told us that they absolutely will not grant anything more than a one-year extension to our current 1115 waiver. So if we were looking to extend for anything beyond that, we would either have to renew the entire 1115, warts and all, or we would have to shift to a different source of federal authority that would still allow us to draw down federal funding. And our concern is that this bill wouldn't let us do that.
And I appreciate that answer, and I think probably the goal of this committee and all of us here is not to have a constituent out there that's in need be shut out. And so that's my concern. If we're trying to actually vote on something that may have an impact that shuts somebody down until the next administration makes that decision. So that's kind of my concern. Thank you.
Representative Kelly.
Thank you, Madam Chair. And Sarah, when would you normally go out with the RFP for the next contract?
Sure, Madam Chair. So for CanCare 1.0, the RFP was issued about 13 months before the contracts went live. For CanCare 2.0, it was a little bit longer than that, about 13 to 14 months, a couple weeks longer. We're hoping to give the state a little bit more time this time around to make sure that we have plenty of time to review all the bids and that we have plenty of time to do a really thorough implementation of any new contracts. So what we're hoping to do is to provide a little bit more than your 13-month mile marker. So that's why we're shooting for hopefully October of this year, which would give us 14 to 15 months lead time between when the RFP goes out and when the actual contracts would go live in January 2024. That's our current plan.
So could you, I mean, if we want whoever the next administration is to have a chance to deal with it, delay the RFP until after the first of the year, and if the administration stays the same, you're probably working on it anyway, and if the administration changes, there's still a compressed timeline, but still probably a long enough timeline to get the RFP out and back and make a decision, and they could have their imprint on it. Is that a feasible thought or not?
Madam Chair, under that scenario, we would still definitely need to extend our current managed care contracts and our current Section 1115 waiver, because we really can't issue an RFP and have contracts go live any less than 13-month time period. So if we're talking about issuing the RFP, say in April of 2023, we would still need that additional time to have those contracts go live. So I think under the situation that you're talking about, where we're unable to issue the RFP this calendar year, we would need to extend the MCO contracts for at least 1 year.
Representative Lynn.
Thank you, Madam Chair. I'm curious to know when it's decided how many MCOs are used. Who decides that, and when is that decided?
That's a great question, Representative and Madam Chair. So CanCare has always had 3 MCOs. There's a reason for that. It's not an arbitrary number. And the reason is that we need to have competition and we need to have a choice for Medicaid beneficiaries. So you can never have fewer than 2. Our concern is that if we only had 2, if something happened with one of the MCOs and they pulled out of the state, we'd be in violation of federal law because there wouldn't be a choice for Medicaid beneficiaries. On the other hand, we're concerned that if we had 4 MCOs, they would be dividing up the business of the state too narrowly that it really wouldn't be financially feasible. So under the past administration, and while we haven't made any official decisions, we're not planning on deviating from the 3 MCO plan, because it really does seem to be the optimal number for a state our size.
So it's the administration that decides how many MCOs there are?
Madam Chair, yes, it would.
Yeah, but I think with the size of what Kansas is, I think Sarah's exactly right. It's kind of become that whatever. The best number, there we go, thank you. Some days I can't speak. For Kansas to give that competition clear across the state so that you can choose. Further questions? Sarah, a couple of questions I've got is, has there been talk within the department or anyone else to show preference between for-profit and nonprofit applicants in the upcoming RFP process?
Madam Chair, that's also a good question. And no. What we want is the most qualified bidders. I don't think we will care particularly one way or the other if the company bidding is nonprofit or for-profit. What we want is the top 3 vendors who can provide this service and provide it competently. And if it so happens that one of those bidders is a nonprofit, we wouldn't discriminate against them for that. But what we want is to make sure that we have the best possible vendors providing the service.
So then if you have a bidder that's a for-profit and a nonprofit, which would they be looked at, as a nonprofit or as a for-profit?
Madam Chair, we would apply the exact same standards regardless of whether they're a profit or not for profit. The successful vendor will have to meet all the requirements of the RFP, all of the federal regulations that are incorporated into the RFP, and that's most of the document, really. It's all federal law. So that's what we will be assessing them on. There will not be 2 different standards for a not-for-profit and a for-profit MCO.
All right, thank you. Committee, are there further questions? Representative Reese.
I think this is my last comment. I don't want us to lose sight of the fact that, we're talking about contracts, we're talking about MCOs, but we're talking about what they provide, the services, and the people who are receiving those services, from, birth to death. So I don't want us to lose sight of that, and I don't know if any people that are receiving those services under these MCOs, what their opinions are, but from all of the emails and text messages and comments on social media about wanting us to negotiate with those MCOs as soon as possible, I mean, I know they're not going to be happy with this at all, and I just don't want us to lose sight of the fact that there are real people out there that are receiving these services.
Well, and I don't know where the quality of care would change with what they're having today.
Oh, but if we
No,
can't negotiate-
mic on, please, that's fine. Representative Reese.
If we can't negotiate these contracts and we're having to wait when there's things that need to be enhanced now, that's where my point is, that we're telling people we're pushing that date back, further back.
Well, and that's why, and I'm not saying this is the exact language that my amendment would end up being, but that's why we want to have the legislature have that ability to do that, so that we don't put that on. As I mentioned earlier, the CCBHCs, we know that we can't halt that. We don't want to stop the enhancement on the postpartum to go to 12 months. We don't want to stop what Representative Carpenter's working with on the IDD, and I wish I could tell you exactly what all that was, but I know enough to be dangerous. So if you got questions, then you should talk to Representative Carpenter on that. And then I think there's might be a few other things that we were looking at. So that's why the legislature would have that authority. Because I always keep in mind consumers, our constituents, and not companies.
Yeah, and I know that about you.
Okay.
I appreciate that about you.
Thank you. All right, any further questions or comments? All right, committee, we have a roundtable discussion tomorrow. If you might recall, we had the long-term care ombudsman came in and was raising some concerns, and I thought the best way to get to answers and the shortest way to get to that was to bring in the individuals that she was making these comments on so that we can hear all from them. So we will stand adjourned until tomorrow at 1:30.